So studies and observations have suggested that there are sport-specific hip disorders. FAI is highly prevalent in cutting and pivoting and abduction dominant sports such as ice hockey, American football, and dysplastic features and hypermobility are highly prevalent in extreme range of motion sports such as ballet and gymnastics. So I'm going to first present a recent study that we've completed looking at National Hockey League, our professional league, ice hockey players. And then I'm going to review the available literature with regards to hip morphology development and prevalence in athletes, in particular high-level athletes. So this is a study that we've just done looking at radiographic hip anatomy correlates with range of motion and symptoms in National Hockey League players. So this is a cross-sectional study, evaluated all players with one organization in the National Hockey League. And we did this at the preseason history and physicals. Demographic data was recorded. Physical examination was performed by 2 fellowship-trained orthopedic surgeons looking at impingement signs and range of motion with goniometer. Standard radiographs were obtained on all of these athletes with an AP pelvis of both hips and a 45-degree modified Dunn view of both hips. Radiographic measures were recorded, and these were all performed in a blinded fashion by 2 fellowship-trained hip preservation surgeons. There were 118 hips and 59 professional ice hockey players. The mean age was 24. 59% were forwards. We did do inter-rater reliability prior to the study, and we found this to be good to very good for both physical examination and radiographic evaluation. So with regards to radiographic anatomy, measures of retroversion, 64% had a positive crossover sign, 86% had a positive posterior wall sign. The mean lateral center edge angle was 28 degrees. The mean alpha angle on the lateral was 61 degrees. So in the end, more than 60% of these athletes have acetabular retroversion. 21% had dysplastic features based on the lateral center edge angle. And 85% had cam-type morphology if we look at the alpha angle, and 89% if we look at the head-neck offset ratio. So if we look at hip range of motion, the mean flexion was about 107 degrees, and internal rotation was somewhat limited at 26 degrees. And 45% had current or prior history of hip or groin pain, and 12% had had either a hip arthroscopy or pubalgia core muscle surgery for what we know as a sports hernia. So if we look at the relationship between hip anatomy, range of motion, and symptoms, what we found is that if you have a higher AP, lateral, or maximum alpha angle, this all correlated with decreased hip internal rotation, which is no surprise. A greater AP alpha angle correlated with less hip abduction with the hip extended, which makes sense. A greater lateral and maximum alpha angle correlated with decreased hip flexion and abduction, sort of a butterfly position. None of the acetabular parameters correlated with range of motion. And only decreased hip external rotation correlated with a current or prior history of pain or surgery. None of the other range of motion parameters did. So hip anatomy in these NHL hockey players was characterized by highly prevalent cam morphology, which we see in other sports, acetabular retroversion, and also fairly highly prevalent dysplastic features. There was greater cam morphology that correlated with decreased hip internal rotation, extension abduction, and flexion abduction, but none of the acetabular parameters correlated with range of motion. And again, only decreased hip external rotation was predictive of hip-related symptoms or surgery. So just what about a little brief review of the effects of athletics on hip development and hip morphology in athletes? So Professor Siebenrock had a couple of very nice studies here looking at this. This is one study, 72 hips in basketball players compared to a control group of 76 hips. Internal rotation was decreased in the athletes. The maximum alpha angle was significantly elevated in the athletes, finding that athletes had about 10 times the risk of non-athletes with regards to having a cam deformity. They also did this study looking at young elite male basketball players, 9 to 22 years of age-matched non-athletes, and looking at these individuals before and after the closure of their growth plates or physis, finding epiphyseal extension increased at all positions for the athletes, and really bringing up the point that the cam deformity might be the result of growth plate alteration rather than reactive bone formation. And this may be analogous to the development of proximal humeral retroversion that we see in our throwers. Here's a systematic review that Jeff Neppel and John Clohessy looked at 9 articles, basically found that high-level male athletes are 1.9 to 8 times more likely to develop a cam deformity. And so really what we're finding in these athletes is it seems to be more of an effect either on the femur or just not appreciable on the acetabular side. When they pooled the cam prevalence and the alpha angle, they found that 41% of their athletes had cam deformity with a mean maximum alpha angle of 61 degrees compared to 17% and 51 degrees for the controls. So again, all of these studies are consistent. So what about hip morphology in athletes? This is a study that we published in 2013 looking at National Football League athletes, 239 male hips. 87% had radiographic parameters consistent with FAI. The most interesting thing for me in this study was that the larger the cam deformity, the more likely these players were to develop or have a history of symptoms. Jeff Neppel and John Clohessy also had a study looking at 2 years prior to this, showing again a high prevalence of cam deformity or pincer type FAI, and also showed that the higher BMI athletes had an increased risk for global overcoverage. Here's a study looking at elite soccer players. They did not have as high a risk as we're seeing in ice hockey players or football players. Cam deformity in 68% of males, 50% of females. Another study here, this was looking at asymptomatic elite ice hockey players using a 3T MRI, and as was mentioned previously, nearly 2/3 of these individuals without symptoms had a labral tear or evidence for hip impingement. And they only looked at cam-type morphology. They didn't even look at the acetabular side. And then they followed these individuals up 4 years later just to see what happens. Now, they only had 2/3 follow-up, but basically, only 1 player missed any games and 14% developed symptoms. So the majority of these individuals, these athletes with these findings on an MRI, will remain asymptomatic at least through their athletic career for at least up to 4 years. Here's another study looking at elite ice hockey players, again just showing an increased prevalence of cam deformity in the hockey players versus the non-athletes. And this is a study we did looking at our butterfly ice hockey goalies. So really a high-risk individual with regards to their high range of motion. And what we found was the cam deformity was greater in magnitude and more lateral in the ice hockey goalies when compared to other position players that were also ice hockey players. And again, also found that acetabular dysplasia was very common for these goalies, upwards of 29%. Here's a study looking at cam-type morphology in elite ice hockey players. What they found is 69% had cam-type FAI. They used a frog lateral, so I think their numbers were a little lower than what we found in the ice hockey players. This is also an NHL study. We used a modified Dunn, which maybe is why we have a higher prevalence of cam-type FAI. But again, finding that the goalies had the highest prevalence and also had the least acetabular coverage. And then lastly, this study that just came out looking at elite ballet. Again, just showing a dramatic difference with respect to, number one, obviously there's a lot of females in these studies, but also the hip morphology is dramatically different than what we see in our ice hockey players, football players, basketball athletes. This is a professional ballet company, and what they found is that the cam deformity was present in 50% of males and 12% of females, but most striking, there was dysplastic or borderline dysplastic features in 92% of the females and 74% of the males. So I would say in conclusion, vigorous athletic activity during critical growth periods appears to predispose to the development of cam-type FAI. Again, may be analogous to proximal humeral retrotorsion that develops in our baseball pitchers. FAI is highly prevalent in high-level athletes at a much greater rate than in non-athletes. And in addition, I think hip anatomy appears to be related to the specific sport or position played, but I think it's unclear, and it's not definitely defined, whether this is activity-specific growth alteration or in some cases natural selection. Thank you very much.